welcome to Let's Talk About Mental Health. I'm Nels and I'm an addiction psychiatrist working in Southern Vermont.
And I'm Robert Stack. I'm a licensed alcohol and drug counselor.
And as a reminder to viewers, if you have comments or questions, we have an email site and a Facebook site. The email address is questions@letstalkvt.com, and our Facebook site is facebook.com/letstalkvt. Yeah, and I think we did have one, somebody write to us that will like to sort of talk about that situation in the show tonight. But I wanted to start off, we like to talk about current events. And a colleague of mine was involved with a webinar with a national audience with a gentleman making a presentation from the Association of Treaters of Opiate Dependence, a group called ATOD. And he made numerous references to Vermont and what we've been doing in opiate dependency with the methadone clinics that have become what are called hubs and central spaces for prescribing methadone and Suboxone, as well as in being coordinated with outpatient practices as well, which we consider usually what we call spokes with our primary care providers and doctors such as myself who do this in an outpatient setting. And what a group of researchers have done in Vermont, and it was published in the Journal of Substance Abuse Treatment this month, was actually look at the expenses for this medication-assisted therapy, which is Suboxone and methadone, for people with opiate dependency, looking at Medicaid patients, since that tends to be sort of the largest insurer that's involved with opiate-dependent people. And looking at the costs of that to see whether it was actually cost-effective to offer as much treatment as the state has been offering.
Right. Yeah. And so they compared two different groups, right? One group that did not get medication-assisted, and one group that did get it, right? And,
right. Yeah.
And it was for what, 2 years, 3 years?
Actually, for 5 years. They looked at, I think it was 2008 to 2013. And they looked at, one sort of a background, they looked at Medicaid expenditures for people with, opiate use disorders, and then the expenses per a year for people without an opiate use disorder. And they found that people with opiate use disorders were incurring nearly 3 times the cost of those without opiate use disorders when we're looking at just people who had the Medicaid insurance. And so making the case then that it's very expensive, the issue of opiate dependency as far as cost of the healthcare system goes. And then they looked at the various types of treatment, which were the methadone and Suboxone, or as they call it, medication-assisted therapy, or MAT for short. And they looked at then also, say, residential treatment, intensive outpatient treatments, treatments that look towards not using one of these medications. And of course, there was considerable expense with this, like in particular the medication Suboxone accounts for maybe about 93% of the Medicaid budget that's being spent on addiction in total. But what they found was that there were significant savings, that the costs of offering these MAT treatments were a good, say, 75%, 25-30% less than the cost of people with opiate dependency who did not have those treatments. So making it look, some of the conclusion was that this actually seems to be cost-effective to offer this treatment, even though on the face of it, you're spending money on the treatment in one case, and you're not spending money on opiate treatment otherwise. But so when you look at all the other expenses, like say rehospitalizations, for example, that the group that does not get this Suboxone and methadone turns out to be a more expensive group to treat or to cover their health needs through Medicaid.
So they were measuring emergency room visits or rehospitalizations, and that's one of the ways that they figured the cost for people not on Suboxone or methadone.
Right. I think that's what they determined was the biggest cost was just those sorts of
treatment is very expensive.
Inpatient treatment, yeah. Oh no, absolutely. I think that Medicaid has come around to not paying for inpatient treatment for opiate dependency anymore. They used to pay, hospitals to do detox treatment. But when you look at the cost of, 5 days of that sort of thing called detox treatment, what you find is that that's enough money is spent on that you could treat somebody in an outpatient setting for a year.
Yeah, now I remember when Vermont, particularly when they first approved methadone, and it was really done for almost said, one of the things they wanted to do was help, like when Nixon approved methadone nationwide, it was part of his war on crime. And he wanted to reduce property crime.
Right, so not war on drugs, but war on crime.
War on crime, that's right. And he did that, and that was the idea. And I think in Vermont, too, I mean, one of the original arguments for methadone was that it would reduce property crime. It would also perhaps reduce the spread of, at the time, we were really worried about Hep C, HIV, but mostly Hep C. We noticed that a lot of IV drug users, not necessarily would have HIV, but we did see a lot of hepatitis C. Yeah. And that was very worrisome. We did the clean needles thing, trying to get needles out there and needle exchanges and stuff. And again, the other concern is when somebody's actively using, that in some ways they're recruiting new users. They're either selling to what I would call naive or beginners, if you will, because they still had assets, they still had money, didn't take as much opiates to get them high. You could buy opiates out of state and resell in the state, and you're constantly recruiting new users to sort of feed your own habit. And occasionally I even heard a lawmaker remark this, that he didn't want to punish some of the low-level pushers, not pushers, but dealers, because they were really just doing it to support their own habit. But, well, there's some truth to that, but they were also selling, I mean, to new users, if you will. So that was the original argument. So now we're saying that not only do you avoid some of these social costs, but it's even cheaper in the long run than just detoxing them or sending them out. But my concern is that when we first started doing opiate treatments, it was a very small community. It wasn't a big community. Now we have so many people. And the other thing is that years ago, a lot of opiate addicts didn't start as young as some of the ones that we see today. They're so much younger. They're in their 20s, as teens sometimes, who are becoming opiates. So how about that transition? Now, you work both in methadone and Suboxone. How about that transition into recovery, as they say, or abstinence? I mean, what's that look like? What do you think is going to be happening?
Well, I mean, we have this discussion a lot, but abstinence and recovery are not the same thing.
Right.
Right. So, I mean, some people, I don't know, do I dare say sort of old school or maybe original notions around recovery was that it meant that you were not taking a medication, and especially with the case of the criticism for Suboxone and methadone being giving an addict a drug for a drug. There's a lot of stigma around that, and it's been a real point of contention in meetings and other communities as well, that somebody determining that you are or are not in recovery based on whether you are or are not taking medication. And so trying to sort of take a step back and look at the big picture, and look at people's quality of life, and maybe sort of then separating out actually how they might obtain a better quality of life.
Right.
I mean, when I meet people at the clinic, part of explaining to them the consent for treatment, so that they understand what they're getting in for with using this strong medication and what the goals are of treatment. What's the point of doing this thing? One of the pieces that I let them know is we have no idea how long people should be on this medication, and that more recent studies are indicating that we should be thinking about years as opposed to months or weeks, and that 5 years seems to be a relatively, say, conservative estimate of how long somebody should be involved with that. But the real point of this is the quality of their life. We want to see them being healthy, having the treatment, and to stop incurring medical expenses. But too, I mean, relationships being reestablished, people be good parents, being good workers, being good partners, developing a role in their community again. I mean, I've been thinking about a few people that I work with. Just this morning, was having a conversation with somebody who had basically recognized that he was not on a good path, and had a stable partner who was doing well, had two children that they both loved, and he realized that using drugs was not who he wanted to be. This is not the kind of man he wanted to become, and so he was looking for treatment and looking for stopping all the drugs, and then sort of keeping things on track, keeping his job, keeping his family intact. And with those sorts of goals driving him, that's the big picture look. That's the quality of life that's involved. And I mean, I would say, who cares how you did that? If methadone or Suboxone was a big piece of that, who has the right to criticize the fact you're taking that medication when you have those higher goals in place?
Now, last week we had Mary Ellen Copeland on, and we were talking to her, and she has that Wellness Recovery Action Plan. And that was originally started primarily for people with chronic mental illness. I mean, that is what they've been using it for. And again, I think I mentioned with her last week, again, that the idea of recovery from a chronic illness is really a quality of life over time. And what you keep track of is, early warning signs or symptoms, medication, taking meds, not getting off meds, or having other people involved in your life. And I remember hearing the federal people, before we got Suboxone approved, said that, what we want to do is get these folks who are using heroin, get them into some kind of medical facility and get them involved with us so that we can help foster recovery and change the quality of their life. And so I think that's, and looking back on that, I mean, that's happening. I mean, that is part of what's happening. And so I again, as you know, I am old school, and I've been, trained in the abstinence model, and that's how we used to recommend for people. But again, I don't mind. I just, I know I have a good friend, Mark Ames, who is very much involved in recovery houses, what they call turning points.
Turning points, yeah.
And these are like, what do you do now? What else can we do for you? This is not just 12-step programs. This is an approach about housing. You work for the Pathways people, right? I mean, this is a thing about getting a job. This is a many facet thing. And it's not just about whether or not you're going here or you're taking meds or whatever it is. It's a much more comprehensive approach to treatment. So I think in a way, I mean, I bring this up only because, I mean, I think that, people talk about it being an epidemic. And as you were saying, one of the nice things about this report is they use. Well,
they call it a public health emergency or public health crisis. Yeah, because we've criticized the idea of an epidemic. I mean, that's when you have, cholera in your drinking water. It's when you have the Zika mosquito that's spreading all over the place. Flus, for example. And this has... That just has a whole different quality.
An addiction is a little bit different. I mean, it is a style, it's a way of life. There's lots of other things involved in recovery and addiction. Like you said, not just abstinence, not just medications, but so many other things. And I know you've talked about that in the past.
Oh, yeah. I mean, like, I mentioned Turning Point. My Turning Point in Bennington got a grant to coordinate with the Bennington Housing Coalition, because recognizing, how difficult, a lot of the consequences from addiction, and that can include, homelessness as well as, being unemployed and illness as well. And having these sorts of agencies working together rather than expecting someone who's struggling with addiction to navigate all these pathways, which are very difficult to navigate, maybe put them all in one place so they can start to work on rebuilding their entire life.
And this has been a real case of trying to get ahead of some of this stuff. I mean, the influx of opioids, prescription pills, and then the influx of, it used to be a lot of Vermonters went someplace else to get heroin out of state, and that's not true anymore. I mean, you don't have to go anywhere else to get heroin in Vermont. I mean, you can stay at home, but it's really been trying to figure out. It's sort of. Fixing a car as it's moving. I don't know what that expression is, something like that. But it's ongoing. And how do we deal with this? How do we treat this? What's the best approach, and what works and what doesn't work? And I think in some ways that's why that research that you talked about is so useful, because it says, we have studied it. We studied it for 3 years, and we think that it is a wise expenditure of tax dollars to provide people with medication-assisted treatment, because we'll be paying in other ways, either emergency room visits or in rehospitalizations. And again, like I said, and also the great cost of life and the way that they live their lives.
And if people are interested, we have this article available on our website.
Right. The other thing, and then, you know, I was talking to you earlier and I showed it to you. There was an article in the New York Times recently, over this weekend, and it was about grandparents taking care of grandchildren because the parents were involved with heroin and still struggling with getting recovery. And it was a 2-page article. It sort of started on the front page, but it was the pictures, and it interviewed, I think, 5 or 6 different grandparents and talked about their experience.
I think they ranged in age from like 40s to 70s.
And it was really heartbreaking, and I mean, it always is. Anytime you end up talking about addiction and stuff, but you know how it changed their whole life. I mean, they didn't. And they made a point to say, we don't want our grandchildren to feel like they're a burden, or that we didn't want to take care of them. It's just that they really weren't prepared for it, and they weren't thinking they would be taking care of grandchildren, and quite literally. And a couple of the grandparents you could see were still really hurt. I mean, and the chronic nature of addiction, and the fact that it can go on and on and on. Like they talked about one that they let him in the house and they thought he was better, and then I guess there was robbery and all that other stuff. And it's just so tragic. I mean, it's really anything that we can do. And I think, this study, your comments, the work that you do, anything we can do to get them from that active, ongoing addiction, street life, all of that, into our system, if you will, I mean, is really worth the effort. Is really worth trying. I mean, because on the other side, if you read this, one mother, it was just really difficult to read. I mean, on one hand, it's about loving your grandchildren and taking care of them. On the other hand, it was sort of, here we are struggling as grandparents trying to take care of these children and doing the best we can. And not only that, but we have this double loss of our daughter or our son. Most of this was about daughters, it seemed, and also just feeling like, why don't they stop because of the children. So I don't know. I mean, when you look at that side and you realize there is treatment available, and so what if it's opiates? So what if it's a drug for a drug? If it gets them in the system and makes it safe, it makes it so that maybe their life has a quality of life. I mean, by all means, do it. Let's do it. Let's not hesitate. I mean, I know I'm guilty of it. It's very easy to be judgmental about it. It's very easy to say, well, they should just be abstinent. We shouldn't have to give them drugs. And I think we're going to have to figure out how this goes for people in their 20s. Will we be on medication-assisted therapy in their 30s, 40s, and 50s? I mean, I don't know. We don't know.
Yeah, I don't know. And one of the grandparents they talked about remember she mentioned that the judge had asked her at one point, well, how long do you think you'll need to be taking care of your grandchildren before the parents will be able to do this? She said sort of, optimistically that, probably about 6 months. And she said that was 20 years ago that she said that. So I can't imagine. I mean, persons are moving towards this stage of being away from parenthood, and I mean, being a grandfather, there's not the energy for it. There's not the sort of mindset. You're in a different developmental stage. So this is really upsetting the balance of sort of development of everybody in the family, and a lot of them struggle with the sense of, I have to do this. This is my duty to my grandchildren. But then too, there was all the what they've lost by having sort of step back and take that role on, giving up what they sort of expected to be doing at that stage in their life.
Yeah, it was so sad when it was one of the hardest sentences in the article. A mother was said to somebody, I guess, who had rescued and got their loved one to the emergency room. And the grandmother was quoted as telling this person, next time they OD, just hold their hand.
Yeah. In other words, let them die, right?
Yeah. Let them be at peace. And I've heard that before. And when I worked, in the hospital for those 29 years. And granted, I was working with the people, who were really struggling with recovery long term, and many of them had a very difficult life. Families really are struggling, and you get to a point you don't know what to do. You can't help them, you can't stop them. you can't believe them. I mean, it's just,
yeah.
it's a horrible existence.
But and there's some supports out there.
Oh, yeah.
So, I mean, rather than again acknowledging
Yeah.
the pain that families are going through with this, but I mean Nar-Anon, again based on the same idea as Al-Anon, with the 12 steps of AA being part of that foundation. You know, recognizing that you don't bear responsibility, and there is a path to be taken. And I think, and the New York Times article mentions also some other support groups too, right?
Well, these were all online, and again, a lot of times when you're dealing with addiction, you feel like you're in there by yourself alone, and you don't know where to turn. And a lot of times you don't really want to talk about it with your neighbors and stuff, and you know what's going on, though they all seem to know. Yes, it was mothers of addicts, mother of addicts.
Addict's mom.
And then grandparents with grandchildren. And so there was a couple different websites. I'm sure if you found one, you could probably get linked to another one. And there were online support groups and suggestions and things like that. So I would do that.
And of course, Nar-Anon would have local meetings, hopefully.
Now, on a personal note, I mean, not personal like for me and you, but we did get one letter, a question came in, and it had to do with the behavior of someone who their loved one and some friends noticed a change in behavior. And it was a combination, if I get this right, it was a sort of, they're worried that it's possible. And the problem is that the person they're worried about is no longer around. But they noticed there was a change in behavior. They've been on pain medication for their back. They've also been drinking. And now all of a sudden they sort of like disappeared. And they're really worried. Like they never had any indication that it was addiction. But now in hindsight, they're trying to put the clues together and sort of wondering, what do you do next? Or what do you do if you think somebody might be addicted to opiates? How do you handle that?
Yeah. Or even, I think, looking for, like we all do, right, when something like this seems to be more obvious in its aftermath, is how could I have known ahead of time? Right.
And what could I have done to maybe stop it?
And recognizing, too, that a lot of us, particularly professionals, struggle with this notion of, we should be omniscient, we should have known everything, and then maybe omnipotent as well, that if we had known, we could have done something that would have altered the entire course of this. And I think, family struggles with this, too, and especially the ex-partner of 3 years who had sort of was surprised by the suddenness of his partner's departure, and looking back and taking stories from other people, the landlord, other friends' impressions, and putting this together and thinking, I wonder if there was addiction going on here.
And if so, how do we how do we know, and what can we do now? And I think that's really one of the sad things, is that when you suspect someone that you care about or love has entered the wonderful world of opiates, there's not a lot you can do. I mean, I remember one time I had this urge to tell someone to change their locks. You know what I mean? I know that sounds like a smart remark or something, but the idea being that, this course of addiction, it really takes people to places they wouldn't normally go. I mean, and it really changes their behavior. Once they get to a point where, and you hope this is not true, but where they're getting dope sick, and they're trying to avoid that, and they're trying to get money and do whatever they need to get their drug, it really becomes the driving force. It really becomes, this is my goal for today, is to get enough drugs today not to be dope sick. And boy, I'm telling you, for some folks, it's like, wake up and start hustling, whatever that means.
And I think in this case, there were a lot of personality changes that were observed. It sounded like this person's sort of sphere of activity had just sort of shrunk and shrunk and shrunk, right? That there was no longer any kind of activities going on outside of the house, not exercising, not socializing. That was really an ongoing change.
And you have to sometimes step back and realize that the person that you love and know, what you're looking at is the symptoms of an illness. What you're reacting to is no longer that person, but really the symptoms of their illness. And just like some illnesses medical illnesses, you might be put off by their appearance or, whatever, but you still know that you love that person, you still care for that person. And I think you have to do that with addiction also. You have to sort of acknowledge that what you're looking at now, whether it's being deceitful or disappearing, not knowing where they are, in many ways, it is not the person that you're looking at. It is really the multiple symptoms of this type of illness. And it's I don't know how to stop it. And I say this with, licensed alcohol and drug counselor, licensed mental health counselor, over 30 years working in the field. I don't know how to stop it. It has a course. It's like any other illness. And I think you can, I don't know, I mean, maybe there are people out there who are successful interventions and they stopped it and they nipped it at the bud and all that. But I'm telling you, my experience, and I grew up with heroin addicts on my street corner. It has its course, and you can you have to sort of almost wait out the disease. You cross your fingers. You hope they don't die. You hope they don't go to jail. You let them know that help is available. You let them know that you care about them. You probably try and set some boundaries. You do things if there's children, like we were talking about, to protect the children. But boy, the disease has to run its course.
But I'd like to think, though, if you could detect some early warning signs that there might be a chance to maybe have this course not last as long. Something we call secondary prevention.
Yeah.
Right. The first thing, trying to prevent this entirely from happening. But in this case, I mean, there was a drinking history, which should have then had some people concerned about, well, now if we add opiates on top of this, what happens now? Right. Also, there was some back pain here. So, I mean, part of this was like personality changes and change in activity. Sure, I mean, it could be addiction. It could also be that the pain is not being adequately addressed. Even though in this case, I believe they didn't find a source for pain, but pain is very sort of nebulous. It's hard to always put your finger on it and point to some sort of injury or structural issue around, say, a back, for example, that would cause you to have pain.
Yeah, but I can remember you. I mean, to us discussing a patient and coming to realization that they're not even in the contemplation stage of change. They're not even thinking about stopping opiates. Yeah. And often the family is thinking about stopping opiates long before the person who's doing it. And the problem in the beginning of your opiate and alcoholism is that it's a voluntary activity. You just can't get enough. You think it's wonderful. You think it's great. You love drinking. You love getting high. You love cocaine. I mean, it's, the burn in your nose, the twinkling in your hands. I mean, you just love it all and you want it. It's only when you get to a point where you say, I can't do this anymore. I want to stop, and I find I can't stop. And that's when I think you can help them. That's when I think you can intervention. But boy, once you start on that merry-go-round, once you get on that roller coaster, it's awfully hard to get off it.
But I mean, just to, like when we talk about, as you say, people are pre-contemplated, not even thinking about stopping using, sometimes introducing the idea that to develop some discrepancy here, there's not a problem, there is a problem, and sort of get them to think that way. I notice that you're taking your pills and drinking together. You seem to be slurring. You seem to fall asleep on the sofa. That maybe actually pointing out these sort of things earlier on before it starts to develop its momentum. I think this is the kind of how do we sort of stay alert and catch things earlier on.
I used to think. Now we saw today in the Times there was another piece about a reduction in prescriptions for opioids, especially the refill department. But even more importantly, I used to think there were naive people about opiates, getting high, taking a pill, whether it's an oxy or whatever. I don't think there's anybody naive anymore in Vermont. I don't think there's any kids that don't know what they're doing. Because once you start, you have to not use. I'm sorry. That's the only way I know how to stop opiate addiction is to not use it.
Right. As we're developing awareness around that, maybe noticing early warning signs or even not allowing them to develop.